Good morning, everybody. Today I will be talking about vocal cord palsy or vocal cord paralysis. Before we take up with vocal cord paralysis, let us revise the nerve supply of larynx. Now, you all know that the larynx is supplied by two nerves, superior laryngeal nerve and recurrent laryngeal nerve. Now, the superior laryngeal nerve has internal branch which supplies the supraglottis and upper surface of vocal cord. The external branch of superior laryngeal nerve supplies the cricothyroid muscle. The lower surface of vocal cord, the subglottis, and all the intrinsic muscles of larynx are supplied by recurrent laryngeal nerve. Just to give you an idea how the two recurrent laryngeal nerves vary. So this is the recurrent laryngeal nerve on the right side and the recurrent laryngeal nerve on the left side. So any lesions in the left side of the chest are more likely to affect the left vocal cord or the left recurrent laryngeal nerve. The vocal cord paralysis may be classified as lesions above nodosa ganglion, which results in bilateral abductor paralysis, and the vocal cords are in cadaveric position. Lesions below the nodosa ganglion, vagus nerve, or recurrent laryngeal nerve paralysis results in paramedian position of vocal cords. Superior laryngeal nerve paralysis causes bowing of the cord as the cricothyroid, which is supplied by the external branch of superior laryngeal nerve, is a tensor of the vocal cord. So just to revise, the intrinsic muscles of larynx, which are basically abductors, which cause abduction of the vocal cord and opens the larynx, and the adductors, which cause adduction of the vocal cords, causing closure of the vocal cords, and the vocal cord comes in the midline. So the abductors, these are the action, this is the action of the abductor. Vocal cord moves outside, this is the broken arrow, and from the muscular process, cricothyroid muscle contracts and it rotates and causes abduction of the vocal cord. Rest all the muscles are adductors of the vocal cord. Now, laryngeal paralysis on basis of the occurrence can be classified in various ways. It may be a congenital paralysis, as you have already seen, which is there in infants and neonates. It can be an acquired paralysis. The vocal cord paralysis may be unilateral or it may be bilateral. It may be a partial or incomplete paralysis, or there may be a complete paralysis. Depending on the group of muscles affected, it can be an abductor palsy or an adductor palsy. And lastly, it may be a sensory palsy, that is the paralysis of internal branch of superior laryngeal nerve, or it can be a motor palsy, or it can be a motor and a sensory palsy. Looking at the causes of vocal cord paralysis, There are central causes, which can be cerebral concussion. There can be cerebral palsy, encephalitis, which causes spastic paralysis, basilar artery occlusion, again causing spastic and incoordination, vascular insufficiency of vertebral or posterior inferior cerebral artery, anterior inferior cerebral artery, and the lateral medullary branches. Then conditions like poliomyelitis, bulbar paralysis, multiple sclerosis, glioma, etc., they cause a flaccid paralysis. Looking at the peripheral causes of vocal cord palsy, 30% of cases are attributed to post-surgical paralysis, maybe most likely the thyroid surgery. Then there can be trauma, there can be inflammation. Neoplasms contribute to 35% of vocal cord palsy, mostly squamous cell carcinoma of larynx of vocal cords. Then various neurological conditions. Then systemic condition associated with peripheral neuropathy, metabolic conditions like hypokalemia, hypocalcemia, and in 25% of cases, the cause is not identified and they are labeled as idiopathic vocal cord paralysis. Now, how do these patients of vocal cord present to you in clinic? The primary complaint will be hoarseness of voice, a change in voice, weak voice, loss of voice. Sometimes when the patient tries to swallow, he may get a bout of cough. There can be dyspnea, there may be stridor, and there can be cough. So these are the major symptoms which with which a patient of vocal cord paralysis will present. To establish the cause and identify the lesion, various investigations are done. Telelaryngoscopy is a very simple investigation. It can be done in the clinic. 70-degree or 90-degree telelaryngoscope is used, which is attached to the camera and a light source and a monitor. So the picture which you see of the larynx can be projected on the monitor and you can store the image. Then there is a video laryngoscopy, stroboscopy to study the mucosal fold patterns and the movements of the mucosa of the vocal cords, direct laryngoscopy, bronchoscopy, X-ray chest, which is a basic investigation to identify if there is any lesion in the chest, because particularly when there is a left vocal cord paralysis. Other investigations are CT chest and brain, thyroid profile, and electrolytes. Now let us see a few pictures how a normal vocal cord looks in direct laryngoscopy view. Now this is a normal larynx you are seeing through direct laryngoscopy. This is the right cord and this is the left cord. This is anterior and this is posterior. So during phonation, you can appreciate that both the cords come and meet in midline. Now during inspiration, there is full abduction and you can see the vocal cords are fully abducted on both sides and the laryngeal inlet is wide open. During expiration, there is a small gap is left. A small gap is left while expiration. So these are the three positions which you commonly see: full abduction in inspiration, partially abducted in expiration, and fully adducted in phonation. Now let us talk about different type of vocal cord paralysis and which nerves cause these paralysis. First of all, unilateral superior laryngeal nerve palsy. There is weakness of or alteration of voice due to paralysis of cricothyroid on one side and loss of tension of vocal cord, because cricothyroid, which is supplied by the external branch of superior laryngeal nerve, is a tensor of the vocal cord. The internal branch is a sensory branch, and paralysis causes anesthesia of the supraglottic area, causing coughing and aspiration, breathy voice, cough and choking spells, and short phonation time as the patient gets tired while phonating. The laryngeal on examination, the laryngeal inlet may be oblique. There may be bowing of the affected cord in phonation. The treatment is speech therapy, and sometimes Teflon injection will be used to give volume and medialize the vocal cord. Now, bilateral superior laryngeal nerve palsy. This is a very uncommon condition. It causes anesthesia of supraglottic and paralysis of both the cricothyroid muscles. There are episodes of coughing and choking during swallowing. The voice is weak and husky as because of risk of aspiration. These patients are managed by esophageal feeding, by feeding tube or a Ryle's tube is passed, and tracheostomy may be required. Coming to unilateral recurrent laryngeal nerve palsy. So recurrent laryngeal nerve supplies the intrinsic muscles of the larynx on one side except the cricothyroid on that side. So paralysis of all intrinsic muscles cause severe hoarseness of voice. There may be temporary aphonia. Later, voice improves as the paralyzed vocal cord moves in paramedian position, and the normal vocal cord compensates. It crosses the midline and tries to close the glottic chink. The cord will be in a paramedian position, and the paralyzed cord will be at a lower level, and on inspiration there will be no movement of the paralyzed side of the vocal cord. There are a few interesting laws. Siemens law, which says that in progressive lesions of abductors, phylogenetically they are newer, are affected first, followed by adductors which are older. A syndrome needs to be mentioned, Otto syndrome, which is the left recurrent laryngeal nerve palsy in cardiomegaly, and that justifies that how an X-ray of chest may identify few conditions of the chest to diagnose the left recurrent laryngeal nerve palsy. Now this is the direct laryngoscopy view of unilateral vocal cord palsy. You can appreciate this is an incomplete paralysis. The right cord is not moving. The right cord is paralyzed. You can see the broken lines here. The right cord is paralyzed, and during inspiration, there is no abduction of the right cord. Only the left cord is moving in inspiration. Whereas in complete paralysis, unilateral complete paralysis, you can appreciate that the right cord has moved beyond the midline to close the glottis, and loss of abduction and adduction. There is loss of abduction and adduction on the right side, and the vocal cord is in para-median position. Talking about bilateral recurrent laryngeal nerve palsy or abductor palsy, cords in intermediate or paramedian position, they cause severe dysphonia and hoarseness. Later, as cords come to midline, inspiratory stridor develops and there is dyspnea on exertion. Now, these patients, because of stridor and this dyspnea, they would require tracheostomy, and for treatment, various procedures for lateralization of the vocal cord need to be done, which may be arytenoidectomy and vocal cord fixation in lateral position. Now, in cases of bilateral incomplete vocal cord paralysis, so in this there is the vocal cord is in midline in inspiration as well as expiration, and there is severe stridor. This is a rare condition, bilateral complete paralysis of recurrent laryngeal nerve and superior laryngeal nerve. It is a rare condition. In this, there will be total anesthesia of larynx and paralysis of all laryngeal muscles. Vocal cord will be in a cadaveric position. The patient will complain of aphonia, aspiration, inability to cough or a very weak cough. Respiration is normal. Treatment is directed towards prevention of aspiration. Tracheostomy may be required. Epiglottopexy, vocal cord plication, both the vocal cords are stitched to prevent aspiration, and the feeding is done by esophageal feeding tube. Now, direct bilateral complete vocal cord palsy, again you can see bilateral complete palsy. Both the cords are paralyzed, and these patients are prone to abductors become involved much earlier than adductors. Partial lesions of cord are in paramedian position. Isolated abductor paralysis, the vocal cords in median or paramedian position due to spasm of adductors. The vocal cords will be in cadaveric position when all muscles innervated by recurrent laryngeal nerve are paralyzed. And finally, the stage of compensation by normal cord, in which the vocal cord moves beyond the midline to close the glottic chink and give a help in phonation and swallowing. Now, these are the various positions of vocal cord in paralysis. Midline position, median in recurrent laryngeal nerve palsy, 1.5 millimeter away from midline, that is paramedian position in case of recurrent laryngeal nerve palsy, 3.5 millimeter away from midline, this is midline, paramedian and fully abducted. In recurrent, 3.5 millimeters away from midline in recurrent laryngeal nerve and superior laryngeal nerve palsy, which is also called as cadaveric or intermediate position. 7 millimeters away from midline, slightly abducted in adductor paralysis. where the abductors are moving but the adductor is paralyzed, and 9 millimeter away from midline, that is full abduction. Now, how do you treat the cases of vocal cord palsy? Once you have identified, you have to manage the etiology, identify the cause of paralysis, and do a definitive treatment for the cause of the paralysis. In idiopathic conditions, idiopathic, as 25% of cases, there is idiopathic vocal cord paralysis. So, non-surgical treatment is done for that, where you can do a speech therapy and vocal hygiene has to be practiced. The cases where, at least before undertaking any surgery for a vocal cord palsy, maybe a idiopathic or any other cause, after treating the primary cause or etiology, if there is a phonatory gap and you need to do some surgery, so the phonosurgery can be done, that is microlaryngeal surgery. There can be local injections of materials like Teflon, collagen, autologous fat, or botulinum toxin. Then various thyroplasty procedures are there. Type 1, in when the type 1, when there is the vocal cords are in a abducted position, so medial displacement of the cord or medialization of the cord can be done, type 1 thyroplasty. Type 2, when the vocal cords are in midline or paramedian position causing stridor, lateral displacement of the cord is done by arytenoidopexy. Type 3, shortening or relaxation of vocal cord to lower the pitch. Now this type 3 surgery is done, thyroplasty is done in gender transformation operation from female to male, from the female voice which is high pitched to a male voice which is low pitched. So you need to shorten the vocal cord or relax the vocal cord. Type 4, this is opposite of type 3. In this, you are lengthening the cord, vocal cord, or tensioning the vocal cord. And this is required again in gender transformation operations when the male voice is converted to a female voice, or it can be done in vocal cord bowing due to age or trauma. Then another technique is laryngeal re-innervation. In this, the laryngeal muscles are re-innervated using superior belly of omohyoid with ansa hypoglossae nerve implanted in the thyroarytenoid muscle. A word about few other voice disorders. Stuttering, it is disturbance in fluency of speech. Puberphonia, this is seen in adolescent male who continues to have a high pitch child-like voice, which is due to spasm of the cricothyroid muscle. This can be confirmed by Goodsman's pressure test, in which a backward and downward pressure on the thyroid cartilage is given, which improves the voice. And functional aphonia, abrupt loss of voice after emotional stress, causing functional paralysis of the adductors during phonation. In this functional aphonia, crying and coughing is not affected. Then a condition is called phonesthenia, in which there is functional weakness of voice with normal vocal cords. Now, these patients are treated by counseling and speech therapy. Spastic dysphonia is another condition which results in harsh and soft voice due to excessive adduction on phonation. This can be treated by recurrent laryngeal nerve section in severe cases which are not responding to speech therapy and psychotherapy. Another condition is rhinolalia. It has got two types of rhinolalia there, rhinolalia clausa and rhinolalia aparta. Rhinolalia clausa results in hyponasality and aparta results in hypernasality. Thank you.